Are we ready to go?
Ready to go.
Yeah. So, good afternoon and welcome to our second webinar in this series on data to improve mental health in Africa. So, my name's Charlotte Hanlon. I'm based here in Addis Ababa, Ethiopia. That's where I'm coming from today. So this webinar series is being hosted by the University of Global Health Equity in Rwanda. And the mission of UGHE is very appropriate to our topic today, to build the next generation of global health professionals, to eradicate global health inequities and ensure global quality health care, which is every individual in every corner of the globe. And I think what we're talking about today is very pertinent to that mission. So collaborating with UGHE for this webinar is the Centre for Innovative and Therapeutic Trials for Africa at Addis Ababa University and the Centre for Global Mental Health at King's College London. So today our topic is local data for local solutions, improving mental health care delivery on the ground. In our first webinar, which you can still access from the UGHE website, we were focusing on the use of mental health data for national and international level monitoring and planning, particularly thinking about COVID response. But today we're zooming down to the level of the local service, and we're thinking about how data can be used to improve the quality of care. As we all know, there's a drive to scale up mental health care across the African continent. But alongside all of our efforts to improve access to care, we also need to be very mindful of the quality of care. We don't need to just think about quality of mental health care at the beginning when everyone's enthusiastic, but also how to make that sustainable into the longer term. So to tackle this challenge, we've got a fantastic lineup of panelists who I'm now going to introduce you to. So first up, we have Dr. Zamasomi Luvuna. So Zama is a quality improvement technical advisor, currently working at the University of KwaZulu-Natal in Durban, who has experience in management across all levels of government in South Africa and program and project development. And she's the key link person in the multi-sectoral partnership between the provincial academic institutions, government and non-governmental organizations. She's also a Fogarty Fellow for Implementation Science and an Institute for Health Improvement Fellow for Quality Improvement Science. Next, we have Professor Tim Carey. So Professor Carey is a scientist who's a researcher, teacher, trainer and clinician who's currently the director of the Institute for Global Health Equity Research and the Andrew Weiss Chair of Research in Global Health at the University of Global Health Equity in Rwanda. So he's worked as a clinical psychologist in rural and underserved communities in both Scotland and remote Australia. And he has a PhD in clinical psychology, an MSc in statistics, and a postgrad certificate in biostatistics, as well as tertiary qualifications in teaching. So the third member of our panel is Ms. Angèle Ishimwe, and she's currently the Director of Behaviour Change at TIP Global Health. That's a grassroots NGO that achieves lasting improvements in health outcomes by promoting community-driven solutions that will also strengthen health systems. Since 2013, Angèle has undertaken health promotion activities as an education specialist, co-designing a knowledge transfer model to facilitate behaviour change, which has been used by over 1,000 healthcare workers. And she also leads something called the HOPE Initiative, and that's a research project to understand and address factors that affect hopefulness among healthcare workers and healthcare recipients. And the final member of our panel today is Dr. Desalen Tugabu, who's from Ethiopia. He's a quality improvement specialist for the USAID Health Financing Improvement Program here. In a former life, he served as Director of the Policy and Planning Directorate and Clinical Services Directorate at the Federal Ministry of Health in Ethiopia. And he led the National Health System Strengthening Activities in general and the implementation of reforms and guidelines to strengthen clinical care. His teaching and his research address a wide range of topics in public health, including healthcare delivery, healthcare financing, capacity building, primary healthcare, and health information systems. So I hope you'll agree we've got the right people to help us to discuss this topic from a really wide range of angles that I think is necessary for the kind of task that lays ahead for us. Just before we get started, a couple of housekeeping points. We're going to hear each panelist presenting for 10 minutes, then I'll introduce the next person. As they're presenting, please feel free to keep submitting questions to the panelists. There's a chat box at the bottom of your screens. And at the end, we'll have around 25 minutes where we'll be able to put these questions to the panelists and generate a bit of discussion. We'd love to make the webinar as inclusive and as interactive as possible, so please do make a contribution there. And then just finally, a reminder that this session is being recorded and it will be shared across the UGHE website and YouTube and social media channels. So without further ado, I'm going to hand over to our first panelist, Dr. Zama.
Thank you, and thank you for the opportunity to share our work that we've been doing with the colleagues within the university and the team within the Department of Health. So we're really excited to have this opportunity. I would like to have the first slide, please, to just take you through what we've been doing. So really what I want to talk about is more the process and the things that we've done that we've found to help us in integrating mental health into care, primary health care platform in particular. Next slide, please. So I'd like to briefly tell you about our program. Program that we are working on led by Professor Inga Peterson is Mental Health Integration Program, and we call ourselves MINT. And the acronym for MINT is really integration of primary health care into integration of mental health into routine primary care. That's really what the acronym means. The next slide, please. So the key word there is integration. So for us to be able to integrate, we had to first understand how the Department of Health or the health system or the platform is set out to start off with, because we are coming to incorporate a program within activities that were already happening. So I'll take you quickly through briefly what is happening, how the health system is set out in South Africa, because this was very important for us to be able to work within the system. Firstly, you may know that the Department of Health in South Africa is in a process of re-engineering primary care package in the South African context in line with the view and the vision of universal coverage for everyone. So if you see there, we are structured in layers. So where we were focusing really, our work was in the primary health care, which you see there is a primary health care facility. The facility there is really a place where they act almost like a post office. They are the ones who decide who goes up, who comes down, and they're the referral pathway. It's entry point for our care. But part of the process, they've introduced this layer, the community layer, where they're saying we want to strengthen the people who do go out to the households to talk to people, talk about services. So it was very important to understand this, how this is set up. So in our designing our program, we then aligned to this. This is quite important also in building the relationship with the Department of Health. So that even our packaging, even our programs, the approach was aligned to this. Because unlike any other programs that do come into the department, often you find it's the research where you come with your team, you do the work, you go. The NGOs come with their teams, they do the work and go. The difference in quality improvement is that the work and the activities are done by our colleagues within the Department of Health. So this is very crucial in understanding how they work, the culture. You almost have to immerse yourself within there. Right, the next slide, please. So part of immersion is attending meetings. Part of immersion is making sure that maybe even within your team that is going to support, there are people who've worked within the department. Besides being set out like that in terms of a delivery package, there is a way that the governance is then set up, which is what we are aligning out here. So the facilities are, there are PHC facilities, that is then followed by the district level facilities, followed by the provincial and the national. It's very important when you are setting yourself up for the quality improvement projects to be able to be mindful and be able to access all these levels, because that's where then you access, operationalize, and sort of integrate what has worked. Because in most cases, as you are aware, in the health facilities delivery, when you are delivering a package of services, you need people to get endorsement from their seniors to be able to change policy, to implement things. So having all the layers there, it helps you to access the data. Not only that, whatever that you've found works as the change ideas or change packages can then be made into policies or guidelines, which are then embedded in the system. And once those guidelines and policies are embedded, the department then develops indicators that will help you track your work, if it's working or not. The next slide, please. The next thing also that is important in embedding ourselves in activities, we formed teams in all these layers. Remember the governance slide that I shared with you. We then formed quality improvement teams in all the layers, because the one mistake that often we do as quality improvement people, we focus on the facilities. If you are aware, the facility manager cannot decide on changing, introducing a data element, introducing indicators, but you will need all these layers up there. So it's important to then have a quality improvement team throughout the governance cascade. You will find what will be different is the amount of engagement, where in the facilities will be there mostly doing these change ideas, testing changes and developing change ideas. Then you then need to escalate this to the next layer, which is usually the sub-districts and the districts. And really the districts and the province are crucial, because they are the ones who give you data. They are the ones who assist you in adopting the change ideas. Then they are the ones who assist you in developing the standard operating procedures. That will then mean when you are scaling up whatever change idea that has worked, it is supported by an SOP and the indicator set. And the importance about the indicator set and data elements is that that is how our health services are funded within our South African context. The next slide, please. So as you are setting yourselves up with the team that is going to do quality improvement, this is what we then did. We set ourselves up, we mimicked the way the Department of Health was set up. So this is our CQI team. So we have a quality mentor. This is the person who goes out to the facilities, sets up quality improvement teams within the facilities, tries out changes, tests changes with them. Then that person is then supported by the coach, who's then the link between the facilities and the quality mentor who's working on the ground, followed by the improvement advisor, who is then the person who links the team with the provincial and often the national people who are responsible for the policies, guidelines, and also the data. And not only that, they also give you permission to be able to do activities within the facility. Most importantly also is to have a person who's going to run and look after data. Now remember, with quality improvement, data driven. So we need this person who's going to support us in reviewing the data that we are receiving from the facilities, the data that we are analyzing, so that we create that feedback loop. So often the data that they will give to us comes in spreadsheets, it's Excel. We'll then make it into information, make it into graphs, run charts, Pareto charts that we then share and feedback to the colleagues from the Department of Health. Next slide, please. Again, coming back to our MINT project, this is how then we packaged our MINT program. As you can see, we mimicked the way that the Department of Health is set out. So you remember there's a community layer there. We also made sure that there's a package that talks to early detection, tracing at a community level. We followed that with a PHC package. Early detection, case finding. Our primary healthcare services are nurse-driven. One of the things that we discovered when we were working with the colleagues is that they didn't really have a standardized evidence-based tool for screening for mental health services. That's what we discovered, and we developed that tool. I'll talk to you quickly about it. And at the district level, we've got where this is a referral point when they found complex conditions that need further care, they then refer there. So we've then developed a package that talks to that. And then at district level, those specialized strategic thinking, where we sit with the colleagues who are running the programs with the district to then support developing an indicator sets that support us in monitoring the program. Next slide, please. So the one thing also at a facility level to zoom down in, while we were looking at seeing how are they running those programs that are already in existence. For an example, if you look at the HIV program, we found it's the one that was more robust. It was the one with more robust data set where we could track the patient through the treatment cascade. So we took our package of services and mimicked it and walked through and set it up the same way. Unfortunately, some of the indicators don't yet exist within the mental health services, but we're in the process of developing them so that it's easy to also track the mental health patients. So as we're showing you the example there. Next slide, please. Again, also we saw that in terms of delivering the health package, it was collaborative. So we did the same way in also developing our package for mental health services. We then, even with the staffing, so if you look at it, we have a primary healthcare nurse who then plays the role of a case manager, which is the same even with all of the other programs, the way the system is set out in our ideal clinic. You find there are 3 streams. There's a mother and child. There's the one that for chronic conditions where they do the NCDs, they do the infectious diseases, they also do then minor ailments. When we were packaging, we also aligned to that, and then we included a mental health module within the same package or module that they're using for the other communicable and non-communicable diseases. We then, within the facility, trained staff members who were already employed by the Department of Health as behavioral health counselors. So they provide psychoeducation, depression counseling, and adherence counseling. And within the facilities, we found that they were visiting doctors who are enriched, who come in for 4 hours or so. We then also trained them to include mental health. And then we have registered psychologists. These are the only people who are outside the service at the moment, so to say, who then come in and support the behavioral health counselors in terms of delivering the package of services. The next slide, please. We've also co-designed tools with the Department of Health for the PHC, for the community layer, and we're in the process of designing tools that will then talk to the care of the health workers caring for the carers. The next slide, please. And as we are designing these tools, we also look back and see how the Department of Health set their own tools. This is the tool that when we first started to understand how they sort of care for clients who are needing mental health services within the facilities, we discovered that they didn't really have a screening tool. So there's like a screening area that is set up for everything that they provide they do the BP screenings, the vital signs stations, but we found with the mental health, they didn't really have a tool. And together with the team, looked at what can we do, what is required. So they emerged that they needed something that can be scored, so that when the client does then move into the consultation room, there's something that the clinician can look at, in this case, the clinical nurse practitioner, which can be scored, which can give a value. So it gives you an idea of people who need care. So this is the tool, it's the BMH tool that you can see it's got scoring, and it looks at alcohol use, depression, and the anxiety. So this tool, the next slide, please, is currently being used by the Department of Health. I just want to share with you how then we made sure that this tool, which when we first came in, we identified that there's a gap, the tool is missing. And then with the team, they gave us local ideas. How can we design something that will work for them, that will align with the way that they're doing things when they're doing vital signs? We then tested this tool. After testing, then a research process was done so that we could have an evidence-based tool. And the research was then co-designed and co-developed. This tool was then taken up to the leadership, as you remember the first slide where we said, for something to be embedded, you then need authority and someone will then endorse this tool. So with this tool, we then developed even an indicator set that will then say, this is what you have done, these are the results. So this then meant that there's a new data element. After we'd done this, remember we're testing in a small scale. We're just doing this in one sub-district, Majuba. This was then expanded to the whole province of KZN. We currently have now an SOP. We currently have now a data element. This we're working in the process with the National Department of Health to make sure that this tool is then scaled up. We tested the tool in 10 facilities. It has then been spread into 605 PHC facilities within our country, and we're working on then spreading it out throughout the country. The next slide, please. So this is how then we then engage our colleagues when we're testing ideas, when we're extracting data and feeding back to the team. So when we first walk in, we start by having a learning session where we then share the shared ideas. This is how you look like in terms of your data. These are the targets that have been set by the department. And then we agree together, this is where we need to be by setting aim statements, and then training the colleagues on equality improvement. And within that, we then identify people who are going to be coaching, so that as we work with them, when the time comes, when we leave the project, at least there are people who will remain knowing the signs of improvement who can then carry on. We then allow the colleagues to go back to their facilities, and then we target sites using the Pareto charts. Mainly, we try and target those who are struggling, and then we support them. Whatever learnings that we get there, we then come together every 2 to 3 months to work on the learnings and share the ideas. And with that, we've also developed a package on training the colleagues on the data, because we found one of the challenges really is giving us problem is the data and data management and the quality of data. So we've developed like a program that we do with them. And with this, whatever then that works, those are the things that we package as learnings, which are then those things that we take to the senior managers for development to SOPs, the standard operating procedures, policies, and possibly development of indicator sets. The next slide, please. So to just summarize, there's no way you can do this without being multi-level and multidisciplinary, especially if you want to access data, especially because this is a participatory process. Also, it's important not to create parallel systems, find things that work. For example, within our context, there's a meeting that sits on a weekly basis called the NEF Center meeting, where data is reviewed. That's where we sit with them to assist in reviewing with data, not only vertically reviewing mental health, but we review all the programs horizontally. Flexibility and innovation, things change quite rapidly. To be able to change, to be able to look at the data and innovate and go back and change. Building will, very important, because that's how you access the data. That's how then you are able to engage the people. Capacity building is key. This capacity building must be supported by mentorship and supervision. And then the one thing that we're working on that has been working quite well is to develop this robust M&E for mental health services as a team. And also this data element and data set is helping us to get funding for the mental health services. Thank you very much. We'll end there. But as I'm ending, I want to just thank the colleagues who've been supporting this project. These are the team members and the Department of Health playing a very important role, because they are the ones who are doing all this work. We're just supporting them.
Wonderful. Thank you so much to Zama. So it's an incredibly impressive program of work, and you've given us a lot of rich information, which I hope will stimulate some discussion. A couple of things I noticed. So clearly, you know, no facility is an island, and if we're thinking about quality improvement, we need to have a system way of thinking. We need to understand the system within which we're integrating something new. And usually when we're bringing mental health into primary care, we're talking about something new. So aligning with the systems. And then there's the other thing I guess I took as well away from your talk, amongst many points, was that we need to know what quality looks like. We need to understand what the processes are, and we need to know what, you know, what is evidence mental health care, and how are we going to know what it looks like in this system. So you showed us really beautifully about how that was built into the existing systems, and equipping, you know, the health workers to even be able to see the kind of data they have available to them. So hopefully we'll get a chance to pick up on a few more points at the end in the panel discussion. We're now going to move on to our second speaker. So this is Professor Tim Carey. So we're staying in the Southern Hemisphere, and we're still thinking about under-resourced settings, but we are going to be outside of Africa. This time we're thinking about rural Australia. And Professor Tim Carey is going to share his experience of continuing quality improvement in that setting and how it can be relevant to many of the settings where we work in Africa. So over to you, Tim.
Thanks so much, Charlotte. It's a huge privilege and thrill to be here today to talk about these ideas and to learn from other people. I was really struck with how much the ideas I'm going to speak about overlap with what Dr. Zama has already spoken about. So while my ideas were really demonstrated in rural and remote Australia, living in the very centre of Australia, this journey or adventure for me started in rural and underserved communities of Scotland, where I worked for 5 years in the primary care service of the National Health Service. I then moved over a few years to Central Australia, where the importance of these ideas became really palpable and prompted me to try and learn more about them. So I applied for and had the privilege of being awarded a Fulbright scholarship, which allowed me to travel to Antioch University in New Hampshire, where an organisation there called the Centre for Behavioural Health Innovation worked with rural and underserved communities, health services and education services in helping them establish systems of ongoing monitoring and evaluation. And I was really interested in what the key factors were, learning about what the key factors might be in not only establishing these systems, but being able to sustain them. So that's what I'm wanting to just quickly run through today. Next slide, please, Clement. So really, I was struck, I guess I knew as a clinical psychologist that not everyone was like me and not everyone was as nerdy and into numbers as I was. But it wasn't until I went to remote Australia that I was really struck by the lack of evaluation that was going on and the serious impact that had on service delivery and the judicial allocation of resources, I guess. The long-standing health disparities and health inequities between Aboriginal and Torres Strait Islander people and non-Indigenous Australians are well documented. And from my experience, I would I'm really convinced that this lack of evaluation and a lack of awareness of how effective programs are is a major contributing factor to that. So there was just to kind of reinforce my concerns, there was a report that came out in 2016 that indicated that about $5.9 billion a year is spent by the Australian government on programs for Aboriginal and Torres Strait Islander people, and that represented 1,082 programs in this report. Next slide, please, Clement. What was really striking for me, though, was that the report revealed that of these 1,082 programs, less than 10% had been evaluated at all. And even of the ones that had been evaluated, because of the poor choice of methodology and the quality of the evaluations, very few conclusions could be drawn about the effectiveness of the program. I think that's an appalling state of affairs. So just to illustrate exactly how appalling it is, there were two, from the report, I drew two, I've got two illustrations. Next slide, please, Clement. So Roebourne in Western Australia, which is a small community of about 1,150 people, had 67 local service providers providing more than 400 programs in the community. You know, just a staggering amount of duplication and waste. And in Toomala, a small community of 300 people in New South Wales, there were more than 70 service providers delivering programs and services to the community. Now, when we've only got a finite bucket of money and mental health is such an important service, being able to allocate resources efficiently and effectively to psychological and social programs is absolutely critical. So I really wanted to find out more about it, and that prompted my application to the Fulbright Commission and my travel to the States. Next slide, please. Come on. So this is what I did. Next slide, please. We'll whip through some of these pretty quickly. So with the services that the Centre for Behavioural Health Innovation, BHI, worked with, through the team at BHI, I contacted 24 people in different services and different organisations, 15 of them agreed to participate in my work, and I interviewed them for about an hour each in semi-structured interviews and recorded them. The participants came from a range of different organisations, including health centres and schools. And importantly for me, they came from a range of different levels in the organisations, from health service managers to service providers. Next slide, please, come on. And then this is what I found. You can, yep. So very quickly, as I interviewed these people, what they were telling me came together around 5 main ideas with then some subcategories under those ideas. And it's those 5 main ideas that I want to spend time talking about today. And as I quickly go through them, I'm sure you'll see overlap between what I'm speaking about and what Dr. Zama found in South Africa. So next slide, please. Come on. So this idea, one of the main things that people really emphasised was that you have to want it. Someone said to me, one of the health service managers said to me that you need to learn to get your data and use it or go home. And there was this idea that people had to be really committed. They had to have the right attitudes and beliefs about the importance of ongoing systems of ongoing monitoring and evaluation. But the US was really interesting in that at a federal level, there was policy that mandated that any application for funding for programs and services had to have an evaluation component already built into it. So they had to have an evaluation plan at the time of funding. And these people I interviewed were really clear that without that policy mandate, just through the demands of service provision, regardless of how committed they were to these ideas, they would be gradually eroded over time, just as they tried to get everything done and deliver the services that were important to them. Next slide, please. Come on. So there was a whole lot of talk around the absolute bare necessities that you needed. I think it's essential for every organisation to have some sort of way of being reflective in their practice. And for most folks, that starts out with an evaluation plan or an evaluation framework or a monitoring plan. And there was this idea that at the very minimum, you had to have some systems of being deliberate and systematic in the way that you evaluated services. And they spoke about the importance of having committed people, but also having things like the appropriate infrastructure, resourcing and funding. Next slide, please, come on. So these, the people I spoke to, and this may have been because I accessed them through BHI, but they really spoke emphatically about the value of having external experts come in to teach them about evaluation. I would say that they've really enhanced the public's and our internal knowledge about not just metrics, but really understanding why, how, when you want to move forward utilising data, sharing it and putting it in a format that's understandable for people. And they spoke very strongly about not just having external experts come in and train people in an organisation and then extract themselves, but having an ongoing relationship in a sort of a mentoring or supervisory kind of capacity. Next slide, please, come on. So, ready, steady, go and keep going was another really important theme, that you needed to start small and start realistically, because the data's really only a piece of the puzzle and probably just a small piece. This idea about having systems for reflection, but not just the systems, but also ways to figure out how you can act on that information and mechanisms that allow you to do so. So they saw it as critical that people would be appropriately trained and retrained on an ongoing basis, having ongoing training to cater for staff changes and so on, but also having systems that were embedded so that even though this data collection will always add a little bit, if the systems were embedded, it wouldn't add an onerous amount to what busy clinicians had to do. Next slide, please, come on. And this was probably one of my favourite themes, this idea that it was much more than just collecting numbers and collecting data. Thinking about the shift we've made over time from fearing and not liking the results to an organisation that's embracing evaluation and is proud of the results. We've made mid-course corrections and have improved things, based on the feedback we've received. And they were absolutely convinced that they were able to engage with communities because not just the numbers that they had, but because they were able to demonstrate the impact and the value of the service, and were able to disseminate that widely. Next slide, please, Clement. So, what does it all mean? This was one of my absolute all-time favourite quotes. That this woman said, "It's not enough to just measure stuff. The data's fine and it's good and you need to have it, but it's the bigger story." So I think evaluation coming from just analysis of data without supporting organisations and partners to be able to take that data and disseminate it in a way that touches people's hearts as well as their heads. That to me is the future for evaluation, and that really spoke to a couple of things: the importance of community engagement and the way in which that could be bi-directional. So you could engage with communities, but you could also use the numbers and the data to help you engage with communities in that kind of feedback loop that we've already heard about. And this also spoke to the importance of the external experts who could help you nuance and finesse the message that you were providing. Next slide, please, come on. So just a couple of extra slides. There were probably three key learnings for me that were actually quite surprising. I thought you could just train clinicians to be committed to these ideas and love them as much as I do. But this idea that we really need to be advocating for policy change so that it was not an either-or decision, or not a decision that people could make, that it had to be a part of what we did. This idea that an ongoing relationship in a supervisory or mentoring capacity was ideal with external experts. And this third one I really love. People spoke to me about the fact that with psychological and social programs, effectiveness wasn't an attribute of the program, but was something that was co-created between the interaction of the service provider and the service recipient. So they saw evaluation as a learning process rather than a judgment of the program being effective or not. Next slide, please, Clement. So the key policy and practice recommendations were that the necessary resources to facilitate this ongoing relationship have to be provided, and that's just a non-negotiable aspect of doing this in a quality way. To promote embedded and ongoing monitoring and evaluation that serves a learning and quality improvement function was seen as being ideal, and engaging service recipients at the outset to ensure both the service and the evaluation of the service was relevant and meaningful to them was really important. Okay, thanks, Clement. Thank you. That's it. Thanks, Charlotte.
Great, thank you very much, Tim. So I think we're already seeing some reinforcement of some of the messages that are coming out of these presentations. I think we heard again, how important about external facilitation, that just sort of training health workers in quality improvement and then sort of leaving them and hoping that that's going to happen on its own. So this idea of reinforcement, either through policy, but also through those kind of relationships that QI mentors can bring. So I think we're also seeing that, similar kind of learning from other settings that, very distinctive from settings in sub-Saharan Africa are still giving us the same kind of lessons. So our first two presenters have been working in the field of mental health. So we started off with mental health integrated in primary care settings, and then we moved to sort of psychological and social programs in rural Australia. Mental health, we're often paying a bit of catch up on the continent, yeah? So we're not sort of embedded in essential healthcare programs. So we're trying to introduce, and we can take advantage of that situation by actually learning a lot from existing health programs. So our next two panelists don't come from the area of mental health, but they have much to tell us about how we can make a jump start on improving quality improvement in mental health services and provision of care. So our next speaker, who is Angèle Ishimwe, is going to tell us about her work with primary care workers, motivating them, engaging with communities. And I'm really interested and looking forward to hearing about, especially about this Hopefulness project, which I think may well get to the heart of how we might be successful with CQI. So over to you, Angèle.
Thank you very much. I'm glad to be here and with a group of experts to discuss about this topic, which is really a cornerstone to achieve sustainable development goals, and especially to share our HOPE initiative and what we are doing, research we are doing around there. Next slide, please. TIP Global Health, formerly the Hangane Project, achieves lasting improvement in health outcome by promoting community-driven solutions that strengthen national health systems. This allows us to enable the scale-up of high-effective solutions to extend access to life savings and quality of care. Next slide, please. With this in mind, we believe that if the primary health care is focusing on relationship between healthcare worker and healthcare recipients, this is a key for us to focus. We believe that the relationship between healthcare worker and the community member they serve is a cornerstone for effective primary care. And with this primary health care, we believe that if we want to access care, we want also receive care, and the community will adopt care recommendation, and this will allow the community to sustain the care recommendation. And this is a cycle that will allow us to prevent the disease, the early diagnosis and the early treatment, and this continue as a cycle. So to make this possible, a relationship between a healthcare worker and the healthcare recipient is for us a cornerstone, and we build it through building the value for healthcare worker, the capability for healthcare workers and both healthcare worker and healthcare recipients, and also the hopefulness for the future for both parties. Next slide, please. If we see at the reality, with that cycle and the continuity of receiving the healthcare recipient to health facilities seeking for care, healthcare workers ended up being burned out. In some countries of Africa, 70% of healthcare workers are burned out. And with that, they are not able to provide a quality of care, because one of the aspect of burnout is lack of a sense of accomplishment. So it is hard for them to deliver a quality care. And if the quality of care is not high enough, the adherence to the care recommendation or the adoption to the care recommendations also is weakened. And this affects the achievement of SDGs. So that is why we focus, if we focus on healthcare worker and the burnout, the well-being of healthcare workers, this will allow us to achieve a sustainable development goal. Next slide, please. The approach that we use, as we are an organization that is an implementation organization, we focus on innovations, co-designing those innovations. But the way we do it, first we listen and learn before we design, because what we do is to co-design our interventions. So when listening and learn, that's where we know where is the gap, what is already exist, and how to build from what is already there. And then we build the skills, but also we take data as something everyone that is beneficial for everyone. First, for our stakeholders, healthcare workers, nurses, and healthcare recipients, because those data is for there to inspire them, to show them what they have been doing by themselves, and also to inform us what are the gaps, where to improve, and what are our strengths, where to keep doing well. And of course, within this approach, we want everything that we do to be sustainable. Next slide, please. With this, we have conducted a prototype within a program that was aiming to prevent both malnutrition and HIV to HIV-exposed infants. And we used this approach of continuous quality improvement in that program to allow healthcare workers and healthcare recipients to both feel valued, capable, and hopeful for the future. So what we did is a secure program that we established in HIV services in 9 health centers. Was started by establishing the goal. We were looking at the Ministry of Health programs, but also we allow nurses by themselves to establish their goals in that services, and also mothers to establish their goals as we were following them. What do they want to achieve to in that journey? We were following them for a period of 2 years. So after that, we defined our pillar of quality care. Those pillars for this service and for quality care in general, we have 5 pillars of quality. One is clinical care. The second one is mother-centeredness. The third one is health education. The third one is data management. And the last one is logistics. So all these 5, once improved, it gives us a good quality service. So with this in mind, we also start a cycle of continuous quality improvement, which starts with sitting down with the collaboration meeting and set our goal, and then identify area of improvement, and then we elaborate a checklist, an observation checklist to observe how the quality is improving, the evaluation. Then we evaluate. Then we inform the healthcare workers and healthcare recipients about what they have been done and what's going well and what's not going well. And they sit by themselves. They do what we call PDSA, Plan, Do, Study, Act. And then they see where they have gap and what they can do, what they are able to do, innovations they can have depending on their capability, and where they want to come from and where they want to reach. So they are the ones to do those activities by themselves. And the cycle continue. With this cycle of continuous quality improvement, we have been seeing some impact. Next slide, please. With this cycle, in 5 years, we have been seeing an improvement of 87% increase in ability of diagnosing malnutrition and 800% in the ability of doing the HIV testing consistently and in qualitative way in the area that we were working from. Also, the malnutrition rate decreased considerably, and also the HIV transmission from mother to child, now it stayed to 0. It went from 1.6 to 0. Now we want to keep that where it was 0. Next slide, please. What we have seen in that journey is through this process, we were able to increase healthcare workers' readiness for change and inspire their future mindset. When we introduced this diffusion of new ideas to know, especially these are our healthcare workers who are innovators, who are visionaries, who feel that they are a majority or skeptics, depending on the way they were seeing themselves in the working area, in their health center, what they can contribute to their community. In 2013, we found 0 innovators and 0 visionaries, but 3 years later, we found there was an increase. We found 10 innovators and 0 skeptics, because they have been seeing through the PDSAs, they have been seeing what they are able to do, innovations that they have been implementing, which led to impact, and like a small taste of change, they contributed not only to the quality of care they were providing in their health centers, but also in themselves, in their readiness for change for themselves, and in the way they are seeing a future. Next slide, please. So this informed us, led us to invest more around hope. The hope that we are defining as a desire for a positive future, and also a belief in a positive future. And this hope, we have Hope Initiative, which is a set and a sequence of researches, because we want to investigate more around hope, because it is a positive psychometric that we really would like to invest in. Next slide, please. In this Hope Initiative, our strategies, first is to establish a tool to measure hope, a tool that we can use in our context, Rwandan context, that can tell us that this hope as an asset was at this level before an intervention, and it is at this level, and the tool that you can really trust. So I will talk about this tool in the following slide. Or also, we want to understand factors that diminish and that increase hopefulness among healthcare workers and healthcare recipients, because those are our key population. And also design interventions that are suitable for them, co-design alongside with them, because we first understand them, see what they believe in and what they believe will work. So we want to also co-design interventions that we believe will work. And then demonstrate that health must inspire hope among healthcare workers and healthcare recipients. And also health systems should be redesigned in a way that inspire hopefulness. Next slide, please. While thinking about hope, this is the way that we define hope, and this is the way that we want to measure hope in interconnectedness, future-oriented mindset, and readiness for change. This is the way we define hope, but also this is a way that a tool that has been initially designed from US measures hope. Next slide, please. So we transculturally translated that tool. It's a tool that is called Heart Hope Index in Kinyarwanda, which is a local language in Rwanda. So what we did at this stage, because we wanted to have a tool that will give us reliable data, so we systematically translated this tool from English to Kinyarwanda, but not literally translating, but transculturally translating it. The first step was for bilingual speakers to translate it from English, to Kinyarwanda, and then have healthcare workers and healthcare recipients as in focus groups to learn to tell us if the questions, if the translated version is comprehensive, acceptable, culturally relevant, and equivalent to, this is for us, we were seeing if it is equivalent to English. But the focus group was aiming to see if each question is comprehensive, acceptable, and then culturally relevant. This was to validate the tool. But also, we learned, next slide, please. After having learning the focus group, this was the end result. The end result, this is the one example. The first question in Heart Hope Index was, I have a positive outlook toward life. And the response option was strongly disagree, disagree, agree, and strongly agree. These are the options. But when we transculturally translated it first, we realized that the way we want the evaluation to be done, it will not be someone to read it, because in our context, we will not find someone who might take the time and will sit and read it and respond to the question, but someone will provide us an interview. So that is why the question changed. I didn't put it here, the English version, but if we translate the Kinyarwanda, the end result Kinyarwanda, the back translation is, do you believe that your life or your livelihood will be better in the future? So to mean that instead of I, we have, do you believe that? And the response option, instead of choosing from strongly disagree to strongly agree, we had these cup options. The cup options is visual, and with the way we wanted it, we want it to be as it is a feeling. The way they respond to the question is, if the question is asked, you ask also the respondent to fill in the cups, the feeling, and choose one cup that fits the response. So if we still have this first question, instead of saying choose among strongly agree or strongly disagree, we were saying compare your belief with the cup's illustration to indicate which cup best fits your answer. So they were having to choose one of the cup. Next slide, please. So after having the final Heart Hope Index in Kinyarwanda, the next phase was to test its properties. So we conducted a survey with 206 healthcare workers and healthcare recipients, and our aim was to test internal consistency of responses, if the response they are giving really the consistency of responses. The second aim was to test the reliability of responses, if the responses are not changing within short period of time. So we were giving here 1 week to administer the survey, and then 1 week after we administered the same survey to see if there is no big change between responses. And then the third were to confirm if the Kinyarwanda version is reflecting the 3 factors of Heart Hope Index. As I was saying, the interconnectedness, future mindset, and readiness for change. If we still have those 3 factors. So the statistical coefficients in this slide are shown that they are sufficient to tell us that the Kinyarwanda version that is translated can give us reliable, consistent, and factor structure data that we can work from. Next slide, please. After this, what we are doing now is to investigate under factors that are diminishing or factors that are increasing hopefulness. This is the current research that we are conducting. Our aim is to see the interpersonal, individual, and health systems factors that diminish or increase hopefulness. We are conducting this research with focus groups among healthcare workers and healthcare recipients, with 80 healthcare workers and 160 mothers with children under 5. And also because, as I said, we learn and we listen and learn. So we didn't forget about policymakers and researchers. And here also we included the local managers, because everything that is being done at the lower level, it has to include policymaker at the top level, but also local managers to facilitate the implementation. In this research, we are using the COMBI model because we believe that our behavior for both healthcare workers and healthcare recipients can be influenced by the capability, the opportunity, and the motivations that they have. Next slide, please. After this research, we will do the next phase will be to co-design or to design the interventions that will respond to we increase the hopefulness. So we'll try to design system level interventions that can consider the way that healthcare is provided, workflow, data entry, data analysis at the health center level, and then we will see the interpersonal, the relationship between healthcare worker and healthcare recipients, what can be done, how can we help both healthcare workers and healthcare recipients to streamline that relationship. And also, the third one is the individual interventions, to consider what can be done individually to increase the interconnectedness, to increase the readiness for change, or to increase the future mindset for both healthcare providers and mothers in the community. So we also believe that if healthcare systems is well designed, it will respond to interpersonal assets and also individual assets. Next slide, please. We advocate for health system readiness for global health. Thank you.
Brilliant. Thank you very much indeed. A very rich presentation as well. You know, I think all of us worry that quality improvement can be used as a stick to beat up health workers. So it's really great to hear of a real total reframing of that QI is about inspiring. And also I think we'll hopefully have time to pick up later on the points you've made about, well, what are important outcomes for our health system that help us to determine what quality is, and hope sounds like a very promising one. Right, so just mindful of time, we're going to swiftly move on to our last panelist, Dr. Desalegn Tigabu. Just before Dr. Desalegn starts off, can I encourage you all to please keep submitting questions to our panelists? We will have a few minutes at the end, and so we really would like to hear your views. So Dr. Desalegn is going to now draw on his experience, especially from the world of health policy, but also his on-the-ground experience of trying to support continuing quality improvement on the ground. All right, Dr. Desalegn, over to you.
Thank you very much for giving me this in quality improvement. So as said earlier by Charlotte, my engagement with mental health previously was at either policy level or in the integration of mental health in the mental health clinical care in primary health care and the Ethiopian primary health care clinical guideline. So next, data in mental health. I'll briefly talk about the system of profound knowledge by the pioneer Deming. Next slide. Yeah, so if you want to improve, we need to have two knowledge. One is subject matter knowledge, the other one is profound knowledge. So what we mean by subject matter knowledge is a knowledge gained by either doing our graduates, we got some knowledge by training. Want to improve, we need to have the intersection of these two knowledge, subject matter knowledge and profound knowledge. So next slide, please. When you say profound knowledge, it is the interconnection of these four knowledge. One is the appreciation of the system. If you take, for example, mental health care, it consists of several systems. So mental health care at tertiary level, secondary level, or primary care level, or community level is different. So we need to appreciate the system, and its consistencies is one of the foundations for profound knowledge. The second one is understanding variation.
Dr. Dessalin, sorry to interrupt you. The internet connection's a bit wobbly. Would you mind turning off your video? I think we'll all be able to hear you better then. Thank you.
So we need to know, see and appreciate that variation. And with that, we will know whether there is an improvement or not. The third one is knowledge, what people know and understand about the issue or the very important, and psychology of change. Hello, Charlotte, can you hear me?
We're struggling.
So we need to know intervention, what factors, which, can you hear me now?
Yes, I think so. It's improving.
Hello,
so,
Charlotte,
yeah.
can you hear me now?
Yeah, carry on.
Okay, next slide, please. So for improvement, we need data. As said by respected panelists again and again, improvement is a data intensive activity. So the data is used to identify problems, to design interventions, to monitor interventions, and to continuously improve our care. So data plays an important role in quality improvement. Next slide. But both globally and especially in developing countries, there are huge barriers to use data for mental health quality improvement. And Kilbom and his colleagues has identified some key barriers and challenges for the use of data in mental. One is sources. So either we don't have the information technology, the electronic medical record, or if you have it, it may not be used by the practitioners, or the data generated from this technology might not be relevant for the care of the patient. This is one of the challenge. The second one, as also said by the other panelists, is limited scientific evidence for mental health quality measures. So there is a huge challenge, huge gap in mental health quality measures, which I think mental health professionals has to work together and has to come up with some interesting mental health quality measures. The third one, as said by people in the mentorship for mental health quality improvement. The last one is culture. So there are some barriers in integrating mental health or use of data. Next slide. So recently published article about the future of quality measurement for improvement and accountability mentions that if you want to measure quality improvement, we have to make some changes, some assumptions. The first one is we have to move kind of quality measures to a holistic and improvement relevant quality measurement. The second one is we can bring change on the life of the patient, and that should happen also across the setting, community-based, primary care, secondary or tertiary care. The third one is about we need to base our measurement on patient-centered episodes of care. Unlike research and unlike a routine health information system, where we tend to measure either access to care, in quality improvement, we want to improve the process of how we provide the care and the outcome of care. So focus should be on patient-centered episode care. The fourth one is about where to measure, and in quality improvement, measurement may happen at individual clinical level, at a facility level, or at population or community level. So we need to develop key performance measurements for such levels of care. So, and the purpose of improvement, unlike routine health information system and research, we want to improve our care, our practice, and that's why we collect and use data. Next slide, please. So in order to successfully measure for quality improvement, some of the strategies recommended are one, we need to have a measurement plan. So if you are going to have a quality improvement project or activity or an initiative, we need to develop a measurement plan. What is our measurement? What type of measurement it is? In quality improvement, there are three kinds of measurement. These are outcome measurement, process measurement, and balancing measurement. So outcome is what we measure for the patient. Process is what to measure from the care provider perspective. Balancing, if there are any positive system other result of the improvement, should also be considered in our. The second one is where we collect data in quality improvement. We collect data routinely.
Dr. Desalegn.
Patients. So fourth one, classic
Dr.
or traditional
Desalegn.
statistics is not recommended. It's better to plot the data immediately we have it. Yes, Charlotte?
Yeah, sorry. I think
I can hear you.
Unfortunately, I think we're struggling to hear you.
Hello, can you hear me now? Yeah.
Yeah. So, and the time is we're getting a bit late. So I think what we might do is stop. and then we'll start the panel discussions. And I really hope we can ask you specific questions about your experience. So just because we're struggling to hear because of the connection. But thank you very much. So first of all, I'm going to start by asking a question that has been put to Dr. Zama. And that is about what happens when you have a health worker who's resistant to being involved in quality improvement activities? The million-dollar question.
It is indeed. And it's not uncommon because, as you may well be aware, those people who have worked in quality improvement, that when you do come in, you identify the people we normally call innovators. You come into a quality improvement project already expecting that there are people who won't engage. So you start engaging the people that are willing to be part of the process to start off. Not only that, the one thing that has helped us and also in stimulating engagement is data, in sharing people data and indicating how well the program is performing. And often people, once they've seen other people starting to engage, are starting to see improvement, and also having seen their data, that this is where I'm performing. And in most cases, people want to do well. So really, you don't force, but you develop that process and you go in already expecting that there are people difficult to get in, but you then come in expecting that they will follow you, join in along the way, which is why it's so important to have those learning sessions, because it's almost like show and tell. Then you stimulate an appetite to join the program. So there's no one simple, easy answer. Thank you.
Thank you very much indeed. Well, actually, maybe let me move to Angel, because I think you also may have a perspective on the same question, because I think what I heard from you was that as people started getting involved in quality improvement, their perspective towards it shifted just through being exposed. So maybe, would you like to comment on that one as well?
Yes, sure. What involves other nurses to participate in continuous quality improvement is the results that they can see, is the impact that they see they can make with collaborating with others, with working as a team, with like what the achievement will make in their life. As one of the aspects for burnout, one is depersonalization, and another one is lack of a sense of accomplishment. So if they see the impact that they have made, if we share with them the results, and they can see where they were and what they have been accomplished, they celebrate results. So the next time they go in the health center, they keep improving, and they even sensitize within their colleague nurses to work toward to invest in the continuous quality improvement, because what I realized, it requires little effort but more impact. Thank you.
Thank you. And Angel, just while I've got you, so there's been another question for you saying, I was fascinated to hear about your project, utilizing data to inspire hope. Can you tell us a little bit more about why the concept of hope specifically became important to you and your team?
Yes, hope came as the third aspect because we want to inspire not only hope, but also value and the capability. But when all those aspects are there and hopeful is missing, it is like one secret ingredient that is missing to reach to our impact. Also, it is something that seems to be forgotten, but which also have a negative, when it is its gap, have a negative impact to, if we want to create, to build the skill set, if we want to build the capability of someone, and but not focusing on hopefulness, it is like one leg missing. And when I have shared the diffusion of new ideas, when after providing consistent training, evaluation, mentorship, and monitoring and evaluation, what increased is the skill set, is the impact, but also the hopefulness that was increased led healthcare workers to see what they are capable of. That hopefulness also lead them to see a bright, to see what they can do for themselves, for their health center, and maintain that impact. So that is why we've chosen to focus on hopefulness. Yeah.
That's great. And I think, you know, it's quite compelling as an idea that this is, you know, it's a bit more than, motivation seems a bit more sterile compared to a sort of more, a much more sort of value-driven kind of idea of hope. I've got a question now for Professor Tim. Here we go. So the question is, you speak about providing necessary resources to facilitate an ongoing relationship between services and external experts. How can academic institutions contribute to that training and mentorship within low resource settings? Are there problems already addressing this in existence already? So about how this sort of relationship between external experts and services can be, how would that work in low resource settings, and what role would academic institutions have? And of course, any panel members can also chip in, and Tim, if you want to speak to any of the other points, please do. Okay,
thanks a lot, Charlotte. So one of the benefits of doing the work that I did in the Fulbright program at BHI was that they worked in under-resourced settings and low-resource settings. Even though it was New Hampshire, there's quite a lot of poverty in some of the districts of New Hampshire, and for the people I interviewed, as well as the team at BHI, that was one of the benefits they saw of having the policy mandate that evaluation had to be incorporated into the national funding of any program. And it was substantial. It was about 20% of the allocated funding had to be diverted to evaluation. So that was the way that these service organisations accessed the expert evaluators. So there isn't, I wish there was an easy answer. I think one of the benefits of COVID is that it's made people think a lot more creatively about online programs and training options and engagement. So that's a possibility. But at the end of the day, and I'd be interested in what some of the other panelists think, I think these programs have to be funded appropriately and resourced adequately, or they won't be sustained.
Yeah, thank you very much. I might come to Dr. Zama to just pick up on that point, but first of all, just want to see if Dr. Dessalin can hear us. Are you able to hear me?
Yes, I can hear you.
Okay, great. Well, let me get a question to you. So there's a question that's come in about cultural barriers for integrating mental health care within general healthcare environments, and a request for you, whether you have any examples of that. But perhaps also, you know, there's that kind of cultural barrier to the measurement of mental health kind of indicators because they're not part of the existing set of indicators. So perhaps whichever one of those would be you'd like to speak to. So either sort of the cultural barriers for integrating mental health in primary care generally, or about, you know, whether we can get general health workers to value indicators of quality of mental health care. What do you think?
Integrating mental health care in primary health care. I may talk about the practice in Ethiopia. In Ethiopia, recently we integrated mental health in the Ethiopian primary health care clinical guideline, which was it's called as PAC in South Africa and in other countries. So it integrates both acute care, chronic care like HIV, TB, malaria, maternal health conditions, and mental health conditions. So I can tell what I experienced during the training. So most of the professionals, they might have some knowledge about mental health from their previous education, but the way it is integrated into other disease conditions was something very interesting and accepted happily. So aligning it with other disease conditions, and it's symptom based. So the patient may come with some symptoms, but that symptom may happen as a result of a chronic illness or an acute illness or an injury, etc. So that way of starting from a symptom and going all the professionals to identify these conditions in their patients, and that's why it's accepted very happily by the health professionals in Ethiopia. In the limited implementation so far is not yet fully implemented throughout the country, but so far the reaction from the health professionals is encouraging.
Thank you very much. So it was cutting in and out a bit, so I'm just going to what you're talking about. I'll just recap what you were saying. So in Ethiopia, we've been adapting South African guidelines, the practical approach to care kit, which integrates mental health very horizontally. And I think you're saying that that has helped to improve the acceptability to primary care workers, because it's not like it's adding mental health as a standalone piece of extra work. So I'm just going to ask Dr. Zama, perhaps this is probably going to be the last question. Did you want to pick up on the points about how we manage to resource external mentors and coaches and all those kind of other system supports that need to kind of be there for quality improvement to work? How has that been happening in South Africa? How have you managed to resource that?
No, thank you. It's really a good question, particularly where we are saying we're wanting skills that will then be embedded into the system. Yet the skill set is not something that the clinicians are trained on primarily during their preparation as health workers. So they do need support. So what has been happening in the South African context, we found that it's the NGOs that have provided this mentorship and the training support, which hasn't worked optimally because we found the funding is usually given in stints of a year. And part of this process, you really need to develop a relationship with people for you to be able to train them. So that hasn't worked too well. But what we found benefited us in some of the programs that we've had is by deliberately developing a training package for the people within the Department of Health. So that as you are working with them, mentoring them, you're also training them so that they've got access to this training platform. What has really helped also, what Prof. Tim was saying, that availability of this virtual platform, as you can see, as you know, in Africa, places are far-flung, so there are districts which are quite hard to reach. So there's been a blessing and a silver lining in this COVID era, because we've been finding we're able to access many people in terms of training packages, and we're learning new ways of sort of impacting skills, which means even if people are not full-time employees of these facilities, of these institutions that are offering training, people are now theoretically able to offer hours and stints in between to be able to transfer skills, which is something we are working on as a team where we are working at the UGHE. And so we're hoping this will benefit us in the transfer of skills. Thanks.
Brilliant, wonderful. So we're out of time. In fact, we're slightly over time. I'd like to first of all thank our audience. Sorry for some of the technical problems we had. You'll be able to access the full presentations, including Dr. Desalegns's presentation, on the website, as well as the record of discussions today. And of course, a huge thanks to our panelists who really contributed to a very rich experience-based discussion, drawing on, a lot of expertise and experience over a great deal of time. And we really appreciate all of your contributions. This is a discussion I feel could go on for hours, but I think it's time to wrap up today. So a big thank you to everybody, and bye for now. And just to bear in mind, hopefully in the new year, we'll be coming back with webinar number 3, where we'll be going down even closer to looking at the patient's journey and how information can improve outcomes for individual patients. So We look forward to seeing you again in 2021. But until then, have a lovely break. Thank you very much. Bye-bye.
Thanks, Charlotte. Thanks, everyone.
Great.